So I'm going to talk about functional MRI imaging of brain. We don't do it here. Very few centers in Pakistan has ability to do it. Maybe LGH has the ability to do it, but they are not doing it. LGH. Maybe Dr. Alizafar can confirm it. They have 3 Tesla, and I think they have some paradigms available, but they're not doing it. We should be doing it because we are a cancer center, but at some point, inshallah, in future. So this is basically just to tell you this technology is there and it is used for the patient care. The overview. So a little bit of physics behind it. So we used echoplanar imaging for acquiring functional MRI data. Echoplanar imaging is also used for our routine diffusion varied images that we have in every MRI brain. And also we use echoplanar imaging for DSC perfusion as well. So the reason echoplanar imaging is very popular and very useful is because these are fast. So they can acquire real-time data because you can see that there are 2 pulses, like 90-degree pulse and 80-degree pulse, and then there is a rapid change in gradient over a small period of time. And then we are getting signals here. Yes. And I will show you how it is helpful in this case. And second concept about physics is T2 star weighting is very important. T2 star weighting takes into consideration not only T2 decay, but also the local magnetic inhomogeneities. When we add these 2 together, we call it T2 star. And I will tell you, like local magnetic inhomogeneities can be a contrast, like gadolinium, or any paramagnetic component, like deoxyhemoglobin is also paramagnetic. So that's why it's important. So bold imaging, blood oxygen level dependent. There is a concept behind it. So we have to understand that concept, then we will understand the functional MRI. So basically, oxygenated blood is diamagnetic. So it doesn't drop out signal on T2 star weighting imaging because it's a diamagnetic. On the other hand, deoxygenated blood is paramagnetic. So it will cause dropout of signal when it is into the vessel. So what happens that when there is synaptic activity due to neuronal metabolism, there is increased perfusion to that synapse, increased blood to that area. We call it RCBF, relative cerebral blood flow to that area. And that washes away the deoxyhemoglobin and increase the oxyhemoglobin to that area. So the ratio of the deoxyhemoglobin to oxyhemoglobin drops down. Means that the deoxyhemoglobin goes down and it goes up. That's why we get bold signal. And I will tell you how. Again, the same concept. So there is a stimulus to the neuron. Neuron fires because of synaptic activity. And there is a neurovascular coupling. Then there is a hemodynamic response, like more blood to that synapse, more blood. But this more blood to that synapse washes away the deoxyhemoglobin, which is the paramagnetic component, which drops down the signal and increase the oxyhemoglobin to that area. More oxygen is required to that area. Oxyhemoglobin is a diamagnetic, so it has a doesn't drop out signal. So that is a bold signal basically due to oxyhemoglobin.
So even by area, then they will now show more oxygenated hemoglobin, therefore more signal.
More signal than less signal. So again, neuronal activity, increased blood flow, increased oxyhemoglobin, and dilution of deoxyhemoglobin, and increased signal. If you don't understand, don't.
Basically, it is like that rest of the brain which is not functioning, there is only deoxyhemoglobin because the oxygenation is taking place, and nothing is happening over there.
Exactly.
Oxygen is a drop out.
Exactly.
But where the functioning is happening at that particular time, deoxyhemoglobin is replaced by the oxyhemoglobin.
Exactly.
And the signals increase.
Yes, exactly. That's what you got it. And this effect is very transient, like only 4 to 6 seconds. It doesn't last long, that increased oxygen level. So again, on the graph, when there is more oxygen hemoglobin to that area, so more perfusion, so oxygen hemoglobin go very high. This is oxygenated hemoglobin, and there is a washout of deoxyhemoglobin to that area. And its effect is transient, like only few seconds, 1, 2, 3, 4 seconds. It comes back. So that is a board that this causes board signal. This oxyhemoglobin. Again, there is initial undershoot because there is some extraction of oxygen that leads to negative bold effect. Because when there's already oxygen is present, the synapse will take that oxygen and will cause deoxyhemoglobin. So there will be a little drop down because there is more deoxyhemoglobin transiently, like less than 1 second. But then there is a big surge of oxyhemoglobin to that area that will cause bold signal. So technique. So basically, it is a over time imaging by echoplanar imaging, in which the signal intensity changes in each voxel. Like we are just looking for a voxel which is very small, and we change with the change of paradigms, conditions. Like sometimes we ask the patient to move the finger, move the lips, just to see how the brain, that particular area is behaving on bold imaging. The functional MRI data then gets superimposed on the either T1 weighted images or FLAIR images to get the anatomical definition. Because this is the red area is just a functional data, but we superimpose on the MP-RAGE images, T1 weighted images on contrast, co-register. Then we analyze it, and then we load for neurosurgery. Anatomic, the sequences we acquire other than bold imaging is T1 regular, T2 FLAIR with the normal matrix that we require with normal slice thickness. And then we also acquire SPGR, which this is the SPGR is I think GE term, but on T1 that is MP-RAGE. But these are high resolution T1 weighted images, basically. Slice thickness is like 1 millimeter or 1.5 millimeter. The functional sequence specifically has a low resolution, and it has this is a echoplanar imaging with 2 seconds for the entire brain. Like it scans the entire brain in 2 seconds. This is the TR and TE value. FOV is also regular normal size. So here you can see that one volume includes the whole imaging of the brain, one volume. And we acquire the, like, for example, in resting phase, 10 volumes, and when we give stimulus, we give 5 volumes. So we scan the patient when patient is resting in the MRI, doing nothing, 10 times, and then we ask for certain stimulus. We ask the patient to do something, and we acquire again for 5 times. So it's 15 times, and we do it for 6 cycles. 6 times we multiply this, and we get 90 volumes. So 90 times the scan has been done.
Why repeated T? What is the significance?
I will show you. Because we want this over time. We want these signals over time. Like we want to see this board signal over time. This is a task when we give a task to the patient. So this is a signal that we got after a specific amount of time. And this is a patient that is resting. So this is just a zigzag signal without any periodicity in them. So we want this for the period of time. So that's why then computer can combine all these signals into that this signal.
Enhance the signal.
Yes, exactly. Because it's very weak signal, like synaptic activity is very weak. And echoplanar imaging is helping us to acquire this data quickly after a certain amount of time. So hardware we use, it has to be 1.5 Tesla or higher field strength. We have 3 Tesla as well. And head coil with 12 channel, 32 channel. And we should have a paradigm, we should have an arrangement of paradigm delivery to the patient. Like there should be a screen and there should be a headphone in the scanner while the patient is in the scanner. So headphone, he or she is listening to our instruction commands that what we are telling, we can communicate with the patient directly. and she or he can see the instructions in front of her eye, maybe in the form of a booklet or the form of a screen within the scanner. So what are the paradigms? Paradigms are basically commands or tasks based on what we want to get from the patient. Like it can be motor, it can be sensory, it can be visual, auditory, language, memory, like anything which we want from the brain to see the particular information. For example, in foot motor, we can ask the patient to wiggle the toes, like just toes only, not the ankle. We can ask the patient to wiggle the toes. In hand motor, we can ask to wiggle the fingers only, not the hand, because it will cause more motor involvement. So just fingers like this, or hand grasp like this. Tongue motor, keep the teeth closed, but make small tongue motion within the closed teeth. So that is also one of the commands. So we have to optimize our paradigm selection for the patient because patient language barrier, patient education is different. So we have to educate them before going in. So the entire scan take at least more than 1 hour because you have to educate first the patient. Like these are the paradigms. We will tell you to do this, to do this, to do this. You should not move during the scan. You should do this. Then patient will understand, and then patient will do inside the scanner. So it's like 1 hour at least. So we can modify the paradigm according to the language, according to their education level, comprehension level. And also we ask the patient not to move because motion is the killer. If motion is there during the scan, then these small signals will not get any kind of significance. So I will show you that, for example, I just got this pictures from the booklet from the scanner. So for example, visual task, this is a visual task, always look at the small plus letter. So we will ask the patient to look at the plus letter only, not to move the gaze anywhere when the screen will appear this. Like this is a plus task. So you have to just only look at this plus task. Plus task again in the center of the checkerboard. And then we can give a visual motor task. For example, this is another, when you see the hand, you will do finger tapping. And when you see this, then you look at this one, you stop it. And then when you see this cross with the hand, you rest. You don't move the hand. That is a command we are giving to the patient. But when you see full hand, then you can tap your fingers. And keep your eyes open the whole time. That's the other thing. Because we don't want to stimulate the brain other than that area. Even opening eyes with the eyelids will also stimulate the brain because the muscles are used. So here the patient will start moving the fingers and here he will stop. And we will tell the patient. Similarly, foot movement also. So when the patient will see with the cross sign, he or she will get rest. But when there is a foot sign, patient start wiggling toes. And again, red line say keep the rest of the body still. Don't move at all. So patient start moving the toes and stop moving the toes here. And then similarly lip movements, like you can go on and on. Like then there are different other tasks, like word generation tasks, in which we will show the letter and patient will start thinking, not speaking, thinking of words starting with A, like apple, aeroplane, Adam, like all those Ali, like I mean any word, they can start with A. Then similarly M. So here they will stop. When we'll say this plus sign, they will stop here, and then we'll show them again, and then they will start thinking about motorbike or magnetic things or whatever. Start with M, without saying their names, just thinking about those names. So this is a word generation task. Then verb generate task, in which we will tell them about the word, and they will start thinking about their sentences, like you play with the ball or you throw the ball, but they will not speak out those words. They will just think about those words. Cup, take a cup of tea, something like that. object naming tasks. We can show them the object and they can name it, like house, home, checkerboard, sentence. So these are like different tasks that we can give to the patient to do it during the scanner. So when we do this, we get this signal. Like this is the right foot. Patient move the right foot, and there is a signal in the left foot cortex, foot motor area. This is the fMRI signal that we got. Some here, some in the association cortex. And on the word generation, there is a signal in the Wernicke's area on the left posterior temporal gyrus. So these are the basically fMRI signals that we get.
So the occipital area signals are into visualization of that.
We call it like we are not interested in these areas. We are in the in language area. We are more interested in Broca's area or Wernicke's area, and in the motor area we are looking for a premotor area, sensory motor area, or association cortex area. So we are interested in those areas. These can be due to definitely other things which the brain is doing by that time, like visually looking at the screen. Then we have software like to post-process this data, like Siemens. We have Siemens and we have Singo. We are downstairs. They are used for DTI imaging, and then there are like different vendors have different softwares, and then there are some offline also which are present available online that we can use. I've used Dynasuite. So we want to know whether this change in the signal is significant or not significant. So you see that this along the time, like when after some time when the task was given, the red is basically when the task was given. So when the task was given, this is the red area. So you see there is an increased signal in that area, particular area, in that area, the motor cortex area. Again, task was given and there is an increase in signal. Task was given, there is an increase in signal. So you have to see this coupling. That when task is given and then there is an increased signal in that area. But when in the normal brain, like which is not in the area of interest, there will be random distribution. The task was given and sometimes it is up and sometimes it is down. So we are not interested in that. We are interested only in this area, which is motor area. So for example, in feet movement, like when the rest was like red is rest and this is task. So when that task was given, there is a signal in the foot motor area of the brain. So we are interested in that. We want to acquire this data. And clinical applications that like we are cancer hospital, brain tumor is very much because when the surgeon want to cut out that part of the tumor, they want to know whether the eloquent cortex, how much it is involved and how much it is not involved, like motor area, speech area, visual areas. So we can answer them preoperatively by fMRI. Similarly, other diseases can also be looked at by fMRI data. So a little bit about functional neuroanatomy, because this is also important for our routine day-to-day reporting. Like we know that there is a central sulcus. There are articles written that there is a lot of inter-observer availability between the central sulcus identification between radiologists. So it is very important to identify central sulcus. And there are papers written on how to identify a central sulcus. So the deepest sulcus, which goes almost to the interhemispheric fissure, is the central sulcus. You can see that this sulcus is almost touching the interhemispheric fissure. That is one identification. And then other identification is that there is a pars brachita here. Like there are two contiguous sulci here. We call it pars brachita, and the sulcus and next to it is central sulcus. So this is central sulcus. And third is a bigger habit. Every time when you open MRI brain, try to identify a central sulcus, even if it is not in your reporting question. Still, it's a good habit to start looking at central sulcus. And there is a hand knob, which is called reverse omega sign. So this bump into the motor cortex or pre-central gyrus is hand knob. This is a hand motor area. The one medial to it is foot motor area, and then one lateral to is tongue motor area. And the sulcus, the gyrus behind it is like sensory cortex, somatosensory cortex. So some of the corticospinal tracts arise from sensory cortex as well. So this is basically from the anatomy book that our brain with topography of different areas that we have, like tongue motor, hand motor, and foot motor. Similarly, superior frontal sulcus is very important to identify. And the one medial, the gyrus medial to it is superior frontal gyrus. So your motor association cortex is here for language and for motor functions. And I will tell you why. Because if there is the surgery of this area, it will lead to SMS syndrome. SMS syndrome is basically transient loss of function of that particular language or motor function, loss of function, and it will come back. So that's the significance. So you don't have to panic, you just have to wait for 2 or 3 days. After that, the function will recover. And this is the SMA area. So sensory, somatosensory association cortex, SMA. And we call it SMS syndrome, and the surgery of this area is done. So precentral gyrus, we already talked about, this motor strip next to the central sulcus. So again, for example, localizing this tumor. So before localizing this tumor, where it is, because this is frontal lobe and this is parietal lobe. So that's very important to identify the central sulcus sometimes. So we put a line on the central sulcus and the tumor is in the precentral gyrus or motor cortex. It's in the frontal lobe, not behind it, which will be a parietal lobe. So when here, this is central sulcus. You can see the hand of the other side. Here the anatomy is distorted due to tumor mass effect, but you can see that this is the central sulcus coming in. This is part of brachyta. So this is involving the foot motor area. Broca's area. So how to identify Broca's area? Basically, you draw a parallel line to the sylvian fissure, and then you draw another parallel line to the sulcus, which is just next to sylvian fissure, which is 90 degree to the sylvian fissure. This sulcus is sometimes present, or almost all the time. You draw in the line here. So the part anterior inferior is pars orbitalis, anterior superior is pars triangularis, and posterior superior is pars opercularis. So Broca's area is comprised of pars opercularis and pars triangularis. So this is the Broca's area basically. Here you can see pars opercularis, pars triangularis. This is Broca's area, which is a motor language area, word forming area. Wernicke's area is basically posterior part of the superior temporal gyrus. Like if you identify superior temporal gyrus and you go back all the way, that is the Wernicke's area. It is close to the angular gyrus and supramarginal gyrus here. So again, you just have to identify superior temporal sulcus. The gyrus superior to the superior temporal sulcus is superior temporal gyrus, and you go back all the way where the sylvian fissure ends. That is the Wernicke's area. So 95 to 98% right-handed people, which we are, most of us, are left-sided dominant for language. So we have left-sided dominant for language. Like this is a Broca's area, this is Wernicke's area activity, and you can see easily there's very less activity on the other side. So I was talking about supplementary motor area, so SMA. So this is a motor cortex, but this is in the superior frontal gyrus, more anterior to it. Into the frontal lobe, parasagittal frontal lobe. So anterior is language SMA and posterior is motor SMA. So if the tumor is here and we get resection of this tumor here, it will lead to SMS syndrome, which is transient loss of function of these areas. Visual cortex along the calcarine fissures. So in brain tumor surgery, basically, I told you that surgeons want to pre-operatively plan, like when they will take out the tumor, how much deficit will be there, or is there deficit will be there. So functional MRI is one of the tools which can help them to see, to plan their surgery. So it has been proven that fMRI is not only important for the diagnosis, but also it improves survival and it preserves the brain function. And it decreases the neurological deficit after surgery. This is a tumor in the temporal lobe, in the right temporal lobe, medial temporal lobe. So surgeon want whether when I take out this tumor, whether I am hitting the language area or not. And this is the other side. This is not the dominant side. The 99% people are dominant in this side. So I was telling you that 98% of people or right-handed people are left-sided dominant. But there could be a case in which the patient has right-sided dominant for language. So if patient go, without fMRI, a surgeon go in and take out the tumor and patient is after that mute, that is a big problem. So that's why fMRI is helping them. They want to do fMRI. So here, again, tumor is here, but the language dominant is on the left side. So he can go safely without any problem, with confidence that he can go in and take out the tumor. So in OR, there are basically they can do awake surgery also. fMRI is there, but they don't rely on us. Like they can do themselves. Like they can stimulate the cortical area by themselves and see how the language system is preserved or not. So there is a term called awake craniotomy. So patient is awake, they are following your commands, and brain is open. This is called awake craniotomy, and they can do it. And they can see where the language area is, where the motor area is, and they can actually put on the brain. They can put some pin pricks, and they can see that a patient will speak or not speak.
Is it happening in our university?
They did a couple of awake craniotomy cases. Dr. Sadhu and Institute. Yeah, I think they have just started doing it. So they can interrupt that language manually during surgery. So they have neuronavigation. They have intraoperative MRI. Not many centers have it. In Pakistan, I don't think we have intraoperative MRI. And they, I was telling you, electrical cortical stimulation. So they can do it. And awake procedure, awake craniotomy, they can do it also. And then fMRI, DTI, BET scan also helps non-invasively. So advantages of fMRI is non-invasive. It's a pre-operative planning. So that is the biggest thing. It's non-invasive. And it doesn't, it decreases the intraoperative surprises. Just like I told you about the language dominance. So they can go inside and they can take out tumor without any problem, with confidence that this is not the language area. And then definitely decrease the time of operation. So a couple of cases. So this is a case in which the tumor is in the motor strip. So they took it out. This is a post-surgery scan. Patient had left side weakness. So in this, fMRI was not done. Maybe they counsel the patient that you will have a deficit, although this is a glioma and we have to take it out. So, but patient had paralysis and fMRI was not done. But for example, here, so this tumor is in the motor association area, not in the motor cortex area. So this patient is at risk for SMA syndrome because it's a superior frontal gyrus, more anterior to this motor cortex, and the motor cortex is just behind it. And this tumor is also in the SMA area. So this patient is also at risk for SMA syndrome because motor cortex is behind it. So we can also report like fMRI localized the motor gyrus and demonstrate that the contrast enhancing lesion does not involve the foot motor of the primary motor gyrus. It also suggests that the motor SMA is also spared by the lesion. Like that's how you report your wording in the report. Like you tell that fMRI data suggests that this area, this eloquent area, is not involved or involved by the tumor. So then there are some online resources for fMRI, American Society of Functional Neurology. This is called as SFNR. So they have annual meetings and they have a website which is quite good, and they have educational content as well. If I can show you here, you click on it. So educational content. So there are lectures online available on functional MRI and other advanced neuroimaging. This is the course I was talking about that I attended when I was there in New York City. This guy is like a celebrity, like in US. So this website is available for anybody. And now they are also doing research on resting state of MRI, because this was the task-based fMRI. Now they are doing resting state, like they are just without any stimulus, without any task, they are just seeing how the brain is behaving in a resting phase. We call it resting state functional MRI imaging.
You know, there green and things kind of. I was once going through a article in which they were saying that they are decoding the brain activity during the REM sleep.
During sleep, that is, I think, well known. Yeah, how brain function during REM sleep and delta sleep. So I think that this is something to be looked at. So basically, they are doing connectivity because they realize that the different parts of brain are connected to each other through neurons. So they are basically seeing like which areas have high connectivity, like superimposed these waves, which have low connectivity. So for example, they choose left motor area, foot motor area, and right motor area. So they are seeing their normal signal during resting state. So they are seeing that they are kind of superimposed to each other. Red and green are almost superimposed. So it means that they are connected. They somehow know each other. So that's how they are actually doing it for the entire brain. This is called as human connectivity project or human connectome project. Basically, they are doing it. You know that cerebellum is also equal. It has same topography as motor cortex as well. You know, yeah. Cerebellum also has same topography. Like if some part of cerebellum will gone, you will have a motor deficit. Some is gone, you will have a hand motor deficit or foot motor deficit. So everything in the brain has same topography in the cerebellum also. So they found out by this. There is connectivity between cerebellum and the cerebrum. So basically, to build a network connectome map, elaborate the anatomical and functional connectivity within the healthy human brain, and facilitate research into the brain disorders such as dyslexia, autism, Alzheimer's disease, and schizophrenia. Because on schizophrenia, I see my brain normal totally, but this is a mind problem. I don't know what is the actual pathology inside the brain is. So we don't know actually many of the disease. Depression, we don't know. You will see the MRI of the depression as good as any other healthy MRI. But there is depression. Done.
So, one thing, and like the fusion imaging, that is kind of a necessity for quick intervention. As considering all the things which are alternative to this, like for neurosurgeons, they can stimulate the brain during the surgery. Where do you think it stands? How much compulsory do you think it is? Is it something which we can categorize as a luxury, or do you think it comes at the level of necessity and it should be there?
In one slide, I told you that studies have demonstrated that fMRI helps decrease disability after surgery and less morbidity for the patient. So it has been proven that with fMRI, there is better survival by different studies. So coming back to your question, again, because many centers don't do it, even in the USA, not many centers do it. So at this time, I think we are not doing enough. Ideally, it should be done because it helps the neurosurgeon to plan advance. Because when the brain is already open, because when the brain open and they cut the brain, there is shifting as well going on. Brain shift as well. So then things are out of control. But I think if I would be neurosurgeon, I would be much happier. Like if I know even before opening the brain that where the tumor is and how the eloquent brain of area relationship is that, and how the white matter tracts are going on. Like for example, we did a DTI recently. Dr. Sadhvi and Anis actually ordered DTI study in which the corticospinal tracts were involved by the disease. I showed many of the results actually. So they left the tumor which were involving the corticospinal tracts. So they did not extract it out. So it was a benefit. And that only thing helped was DTI, that they knew that this tumor is involving the corticospinal tract. So they left it alone. Similarly, fMRI also, like if, for example, language area, you don't know which side is dominant, number one. And number two, for example, if tumor is in the Broca's area or Wernicke's area, and there is a tumor there, you are doing surgery there, as a surgeon, you want to know. So I think luxury will be like will be a strong word. I would say like it's essential, but if it is available. Perfusion. Exactly. Stroke is actually totally different word.
Yes.
People have done careers in stroke. Basically, stroke is time is brain. So they want to preserve the neurons by going after the clot as quickly as possible. That is the basic goal. And if you do this 1 hour exam, you lose 10 million neurons already.
How much the motor function and recovered and how. It's not good.
The chronic stroke management is more in neurology like cases. It's not and it's just symptomatic, like just do nursing, good nursing care, maintain the blood pressure, maintain the blood glucose. Acute is actually the thing which can make or break. If there is a penumbra on CT perfusion and you preserve that area by doing reperfusion, you save the brain and you save the patient morbidity. That is the thing. After that, everything is bookish knowledge. Like brain will recover after that, like whatever is left. But whatever is dead is dead. So I think fMRI is not in the stroke. I never had read about it, never seen about it.
So we're saying that it will take around an hour for this study. Most of the time is for the counseling. How much time it takes in the MRI machine? If we are going
up to 45 minutes, half an hour to 45 minutes. Counseling is at 3 minutes, I think.
Because after coming to Shokathan, I have learned that it is kind of radiology is kind of demand and supply. When I came here, I have a concept to elaborate my report as much as possible. But here, I found out in the MDTs that the surgeons want something, and what they want is important to them. Other than that, is simply not needed. And that is basically that is basically a rough thing for them.
Exactly.
Noise, exactly. Sir, do you think there is the things which are we are providing to the surgeons, are they craving? Are they really in need of those things? But I'm just saying that are the surgeons? Do you think are the surgeons very much interested, or they will say that no?
So I will tell you that this is the entire my report. Like I was telling the report, this is very comprehensive. So this is the entire report. The first paragraph is the entire fMRI report. So I mean, you have to be concise and to the point, like what they are looking for. There's a tumor in the SMA area, and they want to know whether this is involving the motor area or not. And you are just telling that the fMRI data is showing.
Emphasize the visual.
Not language area, not visual area. Like we're not interested in them. So you have to be to the point.
So that would also reduce the time of the MRI study itself.
Exactly. Exactly. So you have to tailor your needs according to the needs of the. For example, if you go to head and neck MDT, to stop you forcibly, like don't tell me this thing. I don't need this. Just tell me. They will tell you that that'll be the carotid artery, receptive or not receptive. Next case, like we don't have time to listen to our verbose reports.
In fact, the response of Dr. RFJ that teaches us a lot. That they are not interested.
Yeah.
Just leave it.
Yeah, and he specifically mentioned like I don't like long radiology reports. I just need 2 or 3 lines in which our information is needed. T3 and 1 or N2 whatever. And you will see my head and neck reports. They are very concise now. After head and neck. So I learned from them. Like I actually learned neurology from my clinician actually. That is the beauty of Shokathan. Yeah, that you will not see anywhere in Lahore at least.
Maybe radiotherapy से
So, for example, I showed you a case in which they took out the motor area tumor. So that was a high-grade glioma. So they took it out because this turned out to be glioblastoma, or so for the saving, they have to take it out.
जैसा मैं सोचा था कि अगर वो जो लैंग्वेज एरिया जो ट्यूमर से इन्वॉल्व हो तो वो एक लंबी कॉन्स्टेंट नहीं रह सकती पेशेंट तो चाहिए जब बाहर निकले तो पेशेंट को पता लग गया मेरी जो आती
Secondly, this is a low-grade glioma. This is a low-grade glioma. It can be just radiated or having just biopsy and then radiation. That is one option. But since they know that this temporal lobe doesn't involve the language, they can take it out. I have seen actually in my experience fellowship that they took out entire temporal lobe because temporal lobe is not eloquent unless there is a language in there. Temporal lobe is not needed for life, for your daily function. Temporal is just memory and just for your emotions, basically, limbic system. Otherwise, temporal lobe is not needed. But if there is a tumor is in the language area, for example, this tumor is in this side, they will be careful. But they will think twice, or they may not go in for a low-grade glioma. They will just do biopsy. Yeah, they will just do biopsy and come out because they need tissue diagnosis definitely, and then there's a radiotherapy. And for example, if there is an oligodendroglioma, oligodendrogliomas have more good prognosis with chemotherapy. So then they will just do chemotherapy.
मेरे ख्याल में तो अगर वो स्पीच एरिया जो है वो इन्वॉल्व ना हो तो टेम्पोरल लोब मुझे इतनी इमोशनल कॉम्पोनेंट सबसे थोड़े दिखाई
Basically, this talk is not just to give an idea. Like, you know what fMRI is. In future, when anybody is telling you what is fMRI is, you know that's what it is.
This looks like something that will eventually become part of routine brain imaging because surgery can इतना role है. If nothing else, you can at least inform the patient कि surgery के बाद these are the additional complications that you are very likely to have because now we have more information. पहले हमें नहीं पता कि इसका स्पीच एरिया है या नहीं है. अब अगर हमें पता है कि ट्यूमर स्पीच वाले एरिया में है और ट्यूमर निकालना भी जरूरी है, एटलीस्ट वी कैन गिव बेटर इंफॉर्मेशन टू द पेशेंट सो दे कैन प्रिपेयर अकॉर्डिंगली व्हाटएवर दे नीड टू. So I think this will become part of it.
Actually you put it very rightly. In this center in Memorial Sloan Kettering, they are doing routinely resting state fMRI in routine patients, all patients, because this is a cancer hospital. So they are routinely doing resting state fMRI routinely, just like we do DWI. This is part of their protocol. And that was in 2017. So I think they are doing it. And also some centers also doing routinely ASL in the routine part of the brain protocol, routine brain protocol, ASL perfusion. Because ASL doesn't require gadolinium. So they are using ASL for diagnosis of defined diseases, stroke, or tumors, or white matter diseases. So it helps them. So it's like another sequence. And fMRI data doesn't, because these are EPI images, so that doesn't take that long. They're very fast. 2 or 4 extra minutes is not much time. Any questions other than that? Thank you. You're welcome.